So it's 7:10 p.m. I'm going to call this meeting of the Board of Health to order. We'll start with the roll call. Dr. Tyra Stevens.
Sorry, here. I was muted.
No worries. Dr. Scott McNeil.
Here.
Dr. Jen Ibrahim.
Here.
Dr. Marla Gold.
Here.
And Dr. Amit Ismail and Dr. Anna Diaz-Brew are both absent this evening. So thank you all. I'm now going to turn to Ben Hartung for an explanation of the public comment process. But Ben, do we have any members of the public on the call?
There are no members of the public on the call. But I will note that if a member of the public joins or is somehow listening, they can put a comment in the chat or email me at benjamin.hartung@phila.gov. Thank you.
Great. Thank you very much. And we'll note that this meeting is being recorded and will be posted online per city ordinance. Have the members of the Board of Health been able to review the meeting minutes?
Yes.
Great. And are there any questions about the meeting minutes?
No.
No.
There
Move to approve.
Second.
Second.
All in favor?
Aye.
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 Opposed? Thank you very much.
We are caffeinated and efficient tonight, Cheryl.
Yes, can tell. Okay, our agenda this evening, we have 2 items on the agenda: an amendment to the emergency regulation governing the control and prevention of COVID-19, mandating vaccines for healthcare workers and in higher education, healthcare, and related settings. And Joe Rosenberger-Altman will present on that. And then an amendment to regulations governing the control of communicable and non-communicable diseases and conditions relating to monkeypox. Joe, if you're okay walking through that, that would be great. So should we go ahead and start with the COVID related regulation?
Sure. And I'm going to move through it fairly quickly because this is largely updating and making some changes to the existing regulation as opposed to putting on new requirements. But if you'd like me to slow down at any point, please just let me know. Okay. So the first change is, and in the regulation, the draft that you have, additions to the regulation are in bold italics and deletions are in strike through. So the beginning is just whereas clauses, just giving some updates as far as where we are in the pandemic. The first change is adding a definition of athletic training, which I believe my understanding is comes from guidance that health has previously promulgated. So it's not something that's new, it's just being added more formally to the regulation. We then use the term covered healthcare worker. The definition has not changed, but because we're removing the discussion of covered healthcare personnel and simply covering covered healthcare workers and regulating those workers regulating if they are working at healthcare institutions, the institution, or if they are working on their own, the covered healthcare worker directly. We wanted to just make that different than what was covered healthcare personnel. And so we're removing the term covered healthcare personnel, and the kind of the import of that is that it used to be that if there were covered healthcare personnel that were not actually healthcare workers themselves, but worked with healthcare workers, those folks were covered by the vaccine mandate, and that is no longer the case. That is the larger import of that. For healthcare institutions, we're clarifying that it is a person or entity that coordinates or engages the services of covered healthcare workers at a location where healthcare related services are performed or available in person, excluding private homes, personal care homes, and locations which are predominantly retail oriented and providing incidental healthcare related services such as pharmacies. As far as healthcare related services, we're removing the reference to acupuncture, chiropractic care, and naturopathic care services. And for higher education institution, I'm actually going to ask you to go back up. We now have a covered higher education institution that clarifies it is a university college or junior college where more than 10% of the enrolled student population resides in housing provided, rented, sponsored, or contracted by the university college or junior college. So it's being cleared only applies to locations where there is a certain percentage of students that reside kind of on campus, so to speak. And then most of the rest is simply updating these terms to clarify who's now regulated. There's a couple of different changes though with respect to covered higher education institutions. So a covered higher education institution only, if there's a covered higher education institution and there's students that are exempted under that or faculty, then they only need to comply with a testing accommodation if fewer than 90% of the covered higher education individuals that are required to be vaccinated are fully vaccinated. So if 90% or more of the folks that are required to be vaccinated are vaccinated, they don't have to comply with the testing requirements if they're exempt. And the other piece I'm going to note is that the routine testing that's required for covered healthcare institutions and for covered higher education individuals that have an exemption only applies while if the city is in the Center for Disease Control community level of medium or high. So there's a provision on page 5 under paragraph 4A(a) that provides that the testing requirement will be suspended if the health commissioner has certified to the board and posted such certification on the department's public webpage that the CDC COVID-19 community level for the city has been changed to low. And the other change with respect to routine testing is that covered healthcare workers that are not working in a healthcare institution, such as those working in private homes who have an exemption, are not required to test. And then in paragraph 5, there is a requirement for documenting testing. This had previously been provided in guidance, but it's been added to the regulation now. And then positive test results must be provided as provided in guidance as well. And it's updating the penalties provision to make it consistent with the normal provisions under the for violations, of the health code and related regulations. If this board recalls, back in April of 2020, there were heightened penalties that had been adopted by this board. And so this is just putting the penalties back to the kind of more typical penalties under section 6103 of the Philadelphia Code. And I apologize, I think that there's I believe there's one piece that I run. No, I think that's it. I apologize. I was thinking of something that I think ended up not being a change. That is it for my explanation. Are there any questions?
I do have a question. Perhaps when I read through this, I misunderstood. Can we just review the healthcare worker change again to make sure I understand what the change is?
Yes. So the definition from healthcare worker to covered healthcare worker isn't in itself a change. The change is that the regulation used to cover covered health care personnel, which, which had included an employee contract worker, student, or volunteer that was affiliated with a healthcare institution whom performed duties in a building where patients, clients, or their visitors were present, whether or not the duty included direct contact with patients, clients, or their visitors. And so it used to be that folks that interacted with patients or interacted with those healthcare workers that had direct contact with patients were themselves covered by the vaccination mandate. And that is the piece that is changing. And then.
So employees with non-clinical contact are no longer are exempt. I'm still maybe a little confused on this.
I apologize. Yes, that is what is being proposed.
So if they don't have direct patient,
sorry?
so if they do not have direct patient care responsibilities.
Right, if they're not healthcare workers.
Even though they're in the healthcare setting and they're still interacting with
Right, so you could
employees that
still,
do have.
Yeah, so this is frontline workers, like the ones who actually let them into the clinic and back into the office.
so a couple of things. I mean, obviously this is not set in stone, so we can change it, but also a healthcare institution would be free to be stricter than this. So nobody has to relax this in this way, but it's less restrictive as it's currently written.
I guess it says health care related services. It doesn't say direct patient services. So that there is some latitude there. I mean, I would consider our frontline registrants as being healthcare related services.
So I do want to clarify that healthcare related services is a defined term. So it's any inpatient or outpatient medical health, inpatient behavioral health, dental, nursing, medical first responder, pharmacological, personal care home, assisted living residence, intermediate care, adult daycare, long-term care facility, audiology, hearing aid, occupational therapy, physical therapy, athletic training, ophthalmology, optometry, sorry, I reversed those two, or speech language pathology services. And then covered healthcare worker is an individual, including a self-employed individual who provides healthcare related services in person to patients or clients.
Sounds like we have a question of, is the clerk who checks somebody in, for example, in a clinic or in a hospital, is that person a healthcare worker?
It sounds like, I mean, the way it reads is healthcare related services, which would imply that they are.
Yeah, that's how I had read it originally.
I also read that they were, but I was talking about if somebody is working in finance, billing.
Oh, okay.
Yeah.
Okay, that's who I wanted to make sure I understood. That
they never actually
don't have any. Yeah, there's no direct patient contact. I guess the concern, and I appreciate your comment that we can always be stricter. The concern is that though that these staff are often interacting with those healthcare workers that do have direct patient contact. So there's still a little bit of a concern. And then another question is, I just don't understand the reasoning behind striking out the acupuncture and chiropractic care. Why were those deleted?
So I think there was an attempt to be a little bit less restrictive at this point. And again, I want to be clear that this is, up to the Board of Health. This is your decision. This is a proposal. The idea was that these are lower risk situations, but we don't have to keep it as worded.
And they're lower risk because why do we think they're lower risk? Yeah.
Physical therapy and chiropractic care and athletic training all kind of have the same level of risk in my mind, but.
Okay, well, it sounds like is there anybody who wants to keep them struck out, or would you want to keep them? And I think the third is naturopathic, and whether you would want to keep that in as well.
Yeah, I would keep it all in as direct care.
Agreed.
I think so too. I think we're maybe causing some issues later on by starting to exempt certain folks that, you know, a hearing aid is not exempt, but
Yeah.
chiropractic is. It just,
I agree as well.
So we can make that change. Is there anything else that we should either talk through or that you're not comfortable with?
So the one other thing that I thought could be a little bit confusing was that in the paragraph on healthcare institutions, it ends with specifically naming such as pharmacies. That would be exempt, but then under healthcare related services, pharmacological is. So if you have a pharmacist in a pharmacy who's administering COVID vaccinations, wouldn't we want them covered? So I could see somebody reading it saying, oh, I'm not. So I'm just wondering, do we need this such as pharmacies?
Or we could say such as grocery stores. Or just take that out.
I feel like it would be less confusing if we just took that such as clause out.
Okay.
And that way it's just clear, if you're a pharmacist, you are considered still required under the healthcare related services.
So I'm going to, okay, so I just want to, I think we should make note of the changes. And I actually think if we want to make perfectly clear that it's not folks that are directly providing what is defined as the healthcare related services, but also individuals that are greeting patients in connection, like directly in connection, that we make a change for that as well. So I think we need to make a move to amend each item. The other possibility would be to come back with a revised regulation. So Dr. Bedico, I'm going to defer to you on what you want to do.
Yeah, I mean, if the board is comfortable with making each of those amendments tonight, I think we could do that. And, you know, they seem fairly straightforward to me. Are you all comfortable with that? It's fine if you prefer for us to come back to you with an amended regulation.
No, I am. I do think that you might be getting questions from, you know, but again, I think your answer of that, if people are confused, they can, you know, they can either seek out guidance or they can always take a stricter stance. But I'm reading this for the healthcare worker situation. I'm reading this as anybody who is patient facing is still required. And anyone that has no patient contact is not. And I think most people understand that.
So could we amend that last paragraph there to say any individual with direct patient contact in inpatient, outpatient, medical, etc. So having something that says with direct patient contact.
Yeah, I think that makes sense.
Yeah, I agree.
And this is going in the paragraph under
healthcare related services right at the beginning. So any individual with direct patient contact in, and then the inpatient part could continue.
Yeah.
Well, healthcare related services applies to services though. So I think do you know what I mean? So
yeah, I think we have to
change something else.
Yeah.
I agree.
Yeah, if it just says, but I'm just thinking that this maybe should go in the worker section rather than in the institution section.
Right.
Yes.
Yes.
Thank you.
Okay.
So covered healthcare worker, any individual, including a self-employed individual who provides patient-facing healthcare related services in person or to patients or clients. Is that what we're saying?
Yeah, I prefer that term because it's less
a little broader.
ambiguous.
Yeah, it seems clear. Okay. Is there a move to amend to make that change?
So moved.
Wait. I'm sorry.
I
just want to slow down for a second. We're saying was it changing individual to person? Is that the only change? I think.
No, it's changing. So an individual, including a self-employed individual who provides patient-facing healthcare related services in person to patients or clients.
That's fine. I think we should clarify that it is I think we need to clarify that it's any individual who is patient facing where healthcare service related services are provided, because I think you want to cover people that aren't directly providing those healthcare related services.
Right.
So I would say any individual, including a self-employed individual who is patient facing at a location where healthcare related services are provided. Does that?
Are provided in person.
So instead of provides, it's who is, whoever is typing. I don't know.
Yeah, there's an
Who
extra
is-
provides.
Yeah, just give it a provide.
Yeah, thank you.
Thanks.
All right.
I'm trying to do it live here.
Okay.
You're doing a good job.
Do we have a movement, somebody to move to make
So-
that amendment? Yeah,
Sorry.
sorry.
I'm so sorry. So it should say is patient facing at,
At a location.
yes, at a location where healthcare related services
Are provided.
are provided in person to patients or clients. Great.
Are we good?
Yeah. And I'm just going to note that the board members are able to see this on the screen, on the Zoom screen. Is anyone not able to see it on the Zoom screen that needs it repeated?
I'm fine. I'm okay.
Okay.
Great.
Okay,
Proceed, sorry.
great. Is there a move to make this amendment?
So moved.
Second,
Second.
all in favor?
Aye.
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 Any opposed? Okay, great. So the second place we were going to amend. Thank you. Yes, we're going to take out such as pharmacies. So for Marla, this is under healthcare institution. In the sentence, covered healthcare workers at a location where healthcare related services are performed or available in person, excluding private homes, personal care homes, and locations which are predominantly retail oriented and providing incidental healthcare related services. And then we're cutting the words such as pharmacies. Is that correct?
Yes.
Understood.
Okay. Is there a move to adopt this, to amend with this amendment?
So moved.
Second.
Second.
All in favor?
Aye.
Aye.
Any opposed?
Aye.
Great. And then I think our third amendment is where chiropractic is listed.
And acupuncture.
Yes, we're gonna take out, we're gonna unstrike chiropractic care, naturopathic care, and acupuncture. So they all are included once again. Is that correct?
Yes.
Mhm.
Are we good, Joe?
We are good. You guys are doing great. Very impressive on the fly.
Is there a move to adopt that amendment?
So moved.
Second.
All in favor?
Aye.
Aye.
Any
Aye.
opposed? Okay, great. Are there any other amendments that we want to consider? And Joe, anything we need to do before we take a vote on this regulation?
I think technically we should have the board amend the agenda to adopt the proposed regulation as it has been amended at this meeting by the board, just to be safe.
Thank you. Is there a move to so amend the agenda?
So moved.
Second.
All in favor?
Aye.
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 Any opposed? So with that, is there a move to adopt the regulation as amended?
So moved. It's Marla.
Second.
All in favor?
Aye.
Aye.
Any opposed? Thank you all, and thank you for making that better. All
It's
right.
good teamwork. We all took turns with who had the move, who had the seconds. Perfect.
Well, the edits is really what I had in mind.
It was very well done on the call.
It's more clear.
Yes.
Yeah, I think it is more clear, and also it's nice to get it done. So, all right, we're now going to move on to the second item on the agenda, the amendment to regulations governing the control of communicable and non-communicable diseases and conditions related to monkeypox. And Joe, can you walk us through, and I can explain anything in here?
Absolutely. Okay, so this is an amendment to the regulations governing the control of communicable and non-communicable diseases and conditions. And so this is just the standard disease and control listing that the board has promulgated. And it is adding monkeypox as a reportable condition under paragraph 2. And under 10, which relates to regulations pertaining to the control of the infected individuals, contacts, and environment for each reportable disease. It is providing for the reporting, isolation, concurrent disinfection, terminal disinfection, and monitoring of individuals related to monkeypox. So with respect to reporting, the direction is to report to the acute communicable disease control program by telephone or other equally prompt means immediately, and not more than within 24 hours of suspicion. Isolation, it directs that patients shall follow all isolation guidance provided by the Center for Disease Control as it may be updated. But if deemed necessary by the department in a particular case, the patient shall be isolated in a hospital, its equivalent, or home until the communicable period is over. Isolation precautions should be maintained until all lesions have crusted, those crusts have separated, and a fresh layer of healthy skin has formed underneath. Concurrent disinfection, surfaces and materials used by someone with monkeypox or suspected monkeypox shall be disinfected or discarded. Terminal disinfection shall consist of thorough cleaning and disinfection. Monitoring, if deemed necessary by the department, persons who had close contact with individuals with strains of monkeypox will be monitored either actively with phone calls or texts or passively by the individual reporting systems to the department.
So this isn't supposed to happen. However, I'm going to make a suggestion for a change because I'm reading this with thanks to Marla for questions she asked me earlier today. I think we want to say that reporting should happen within 24 hours of diagnosis of a probable or confirmed case. People can report suspicious cases, but I don't think we want to require everybody who swabs something to report to us necessarily.
Thank you for that comment.
So Cheryl, can you restate the wording?
Yeah. So at the end of the reporting clause, it would be within 24 hours of diagnosis of a probable or confirmed case.
So I think we just do the same thing. And I'm just going to note that it's Ben is editing it and the revised language is on the screen for board members to see. And if anyone would like it repeated again, please let us know. And then we'll do the same thing. We'll move to amend this regulation, and then there'll be a movement to add consideration of the amended regulation to the agenda, and then it can be voted on.
Are there any other questions or discussion points there?
How is this going to be communicated?
We would typically send something like this out as a health alert, so a HAN, which it goes to all the healthcare providers in our network.
And that will be after we've approved and you file this. Right,
so it would go through the 30-day. I mean, I would not anticipate a lot of public comment necessarily on this, but we would wait the 30 days for public comment. And in the meantime, I should say, we are putting out lots of information to people about the reporting process, and we wouldn't wait 30 days to try to get more people to report. No other questions or comments? Is there a move to amend as written on the screen and for Marla with the reporting of probable or confirmed cases?
So moved.
So moved. This is Marla.
Second,
I'll second.
all in favor?
Aye.
Any opposed? Great. And is there a move to amend the agenda and Joe, can you give me the correct words for this?
Move the agenda, amend the agenda to add consideration of the, I'm trying to scroll up to the title, I apologize. Of the amendments to the regulations governing the control of communicable and non-communicable diseases and conditions as it has been amended by the board just now.
Do we have a
So moved.
second?
I'll second.
All in favor?
Aye.
Aye.
Any opposed? And is there a move to adopt the amended regulation?
Can I ask one other question, just
Sure.
given that we changed the language there? Is there a need to scroll down to monitoring where it says if deemed necessary by the department, a person who had close contact with individuals with strains? Do we want to modify, pardon me, modify the language so that it's consistent? And Ben, if you scroll back up, the language about probable or confirmed, do we need that there?
I don't know that we do. For a couple of reasons. One, I can definitely think of situations in which we might want to be doing check-ins regularly. So there are suspicious cases and suspicious cases. So if somebody is a contact of a known case and they develop symptoms, even while we're waiting for that test to come back, we're pretty sure that's probably going to turn out to be monkeypox. That's a much higher level of suspicion where we might want to be checking in with that person, as opposed to, someone went to their doctor, they had a rash, it looks possible, they swab it, that technically they're both suspicious, but they're very different.
Okay. Then that was the one thing as we were voting, I was trying to think, okay, do we need that language down there? But that's fine.
Okay, so is there a move to approve the amended regulation?
So moved.
Second.
All in favor?
Aye.
Aye.
Any opposed? All right. Thank you all very much.
Sure.
Yeah, please.
Just one question, kind of similar to the question was asked about the last regulation, but the first one, in terms of, I know we have to wait for the 30-day comment, but are you announcing anything in the morning that updates are coming? Or does that not happen until the 30 days have actually passed?
So I just wanted to mention that for the COVID regulation, it is being adopted as an emergency regulation. So it will be effective upon filing with records. There is still a mayoral declaration of emergency that is active for COVID-19, a mayoral declaration of extraordinary circumstance that allows the suspension of the 30-day comment period. So it is being promulgated pursuant to that, unless the board would like to revise that.
Wasn't looking to revise. I just want to know when this is going to get communicated to the public, I guess. So, there's been lots of people in healthcare facilities asking if there's going to be any changes to this. So I'm just wondering, do you anticipate having some kind of release that the changes are coming? Or are you going to wait till the changes actually occur?
Scott, you're talking about monkeypox now, right? Not the okay.
No, I'm talking about COVID.
Okay.
Yeah, I mean, we can put the information out to healthcare providers in a hand, so we can do that fairly quickly. Will it be in the morning? Probably not quite that quickly, but quite quickly. It usually takes us, just a couple of days to put those together, unless we're doing something dire, which I'm trying to do only when we have to. Any other questions? Okay. that case, I will adjourn tonight's meeting. It is 7:45 p.m. Thank you all very much for giving your evening to the city of Philadelphia. I really appreciate you.
Thanks, Cheryl.
Thank
Good to
you.
see everybody.
Take care.
Yeah.
Yeah.